This is David F. Chang presenting an elderly male patient who is on Flomax. Now, with a pupil that dilates this poorly, one should anticipate a fairly severe degree of intraoperative floppy iris syndrome. And because of that, I'm going to go ahead and make stab incisions in each of the quadrants to place iris retractors. The only one that I haven't yet made a stab incision for is for a retractor that will go just behind the phaco incision. I've also made access points for my right and left hands at oblique angles. After placing a little bit of intracameral xylocaine, I will go ahead and make the clear corneal incision coming in from the temporal side. I'll place some viscoelastic into the eye, and then we'll go ahead and place the iris retractors. Now I'm going to be placing them in a diamond configuration. This was first described by Otting and Omfroy in the Journal of Cataract and Refractive Surgery. And the idea is to maximize the exposure right in front of the phaco tip. These are reusable retractors that are available from Katena. They come in that white autoclavable case, and we're going to then use these in each of the quadrants. I've already made a corneal limbal relaxing incision, and behind that is my stab incision, so we'll start threading the retractors in. These are made of polypropylene. They're blue, and they are 0.15 millimeters in diameter, which makes them equivalent to about a 4/0 suture. Now here I'm actually trying to place one, and at this point I've forgotten that I failed to make my last stab incision. I usually go back after the clear corneal incision has been made, and I make my subincisional stab incision just behind, posterior to the clear corneal incision. But of course we're entering still anterior to the iris root. So this is a separate track for this subincisional iris retractor. And then we'll place the other one off to the left. Now, these are again made of polypropylene, much the same material as a Prolene haptic on an IOL, and they're about the same thickness. So again, this would be equivalent more to a 4/0 suture as opposed to the typical 6/0 nylon retractors. So these are definitely thicker, and being polypropylene instead of nylon, they are definitely more rigid, and you can see that that really facilitates their handling and placement through these stab incisions. Not only that, but it makes them sturdy enough to be autoclaved and reused, hence making this entire system much more cost effective. By turning the little silicone knob, I can rotate this so that the hook engages the pupillary margin, and by then sliding this down we can expand our pupil to whatever size is desired. These are still flexible enough that, as you can see, if the eye moves about under topical anesthesia and the hook runs into the lid, this does not cause any intraocular distortion. We put a little viscoelastic on the corneal surface and wet it, and this provides good visibility. Now we'll initiate the capsulorhexis with an irrigating 25 gauge needle that's got a bent tip to perform the capsulorhexis. So this is serving as my cystotome. You see that the large pupil, of course, not only gives us good working space, it maximizes our red reflex, and this is a technique that is certainly 100% reliable in terms of enlarging and maintaining a well-dilated pupil for cataract surgery. Now, iris retractors have been known to damage the pupillary sphincter, and that's more likely with this amount. Here's the Chang hydrodissection cannula. We're just hooking the capsulorhexis, and then the initial hydrodissection wave will proceed starting in the subincisional area, where it will then preferentially loosen the cortex in this area, and then using the blunt tip of the cannula we can rotate the nucleus and endonucleus, confirming its mobility. Again, we smear a little bit of the viscoelastic on the surface of the cornea to give us good wetting, and we'll proceed to perform horizontal phaco chop using a micro phaco tip and then the double-armed combination chopper with the elongated micro finger on one end that I'm using here for horizontal chopping. Now, one must be careful with a fibrotic pupil, such as a patient on chronic pilocarpine, in terms of expanding the pupil this much with iris retractors, because you can certainly tear the sphincter through and through and create a permanently midriatic pupil. However, with the floppy iris syndrome, usually the pupil is not fibrotic and rather elastic, and I find that I can really stretch it maximally, as you see here, without any permanent damage to the pupil. And in fact, at the end of this case, you will see that there are no tears in the iris sphincter. So it's, in essence, atraumatic to this type of pupil because of the anatomy of the pupil. You can see that the iris beneath the phacotip is actually retracted down and out of the way, and this configuration also maximizes the exposure right in front of the phacotip. Were we to use these retractors in a square configuration, of course, the nearest two retractors tend to tent the iris up, creating a little bit of a hurdle that the phacotip must cross, and frequently there's a lot of chafing of the iris edge, again contributing to iris atrophy postoperatively. So this diamond configuration really improves our access and our visibility, and here we're going after the epinucleus. So the important thing here is that we're avoiding the progressive meiosis that occurs with IFIS. The iris edge is made more taut by stretching it, so we don't see the billowing. And of course, again, being fairly taut, we're less likely to see iris prolapse coming through the side port. And here we remove the epinucleus, and there's not much cortex at all. Now, if you know that the pupil is going to be is going to demonstrate severe IFIS, you're probably better to place these retractors early on. They are more difficult to place if the capsulorhexis has already been made. But sometimes after you perform the rhexis, because the pupil seems reasonably large, you then perform hydrodissection, and it's at that point that the pupil suddenly snaps down. So one of the things that you can do is use a little Lester hook if you want to place the retractors then, and just push the margin away from the capsulorhexis margin. In other words, you push the pupil away from the capsulorhexis margin, making it easier to visualize, and then to preferentially hook the pupil margin with the iris retractor. Now in this case, we're putting in a 3-piece hydrophobic acrylic IOL. It happens to be the AMO Sensor, and we'll inject this into the bag, and as it unfolds we'll see if the capsulorhexis overlaps the optic. I'm showing, and here we're adding a little more viscoelastic into the bag. This entire case has been completely unedited, because one of the concerns is that this is a very time-consuming technique when you use iris retractors. And in fact, I think with a little practice, it proceeds quite quickly, as you will see. And I think one of the things, again, that facilitates the use of these retractors is the fact that they are thicker and stiffer and a little bit more rigid than the nylon retractors. And they're also very easy to see being blue. With floppy iris syndrome, one should really think of this as being of variable severity, and the continuum proceeds from mild, then goes through moderate, and ends up in severe. So with a mild floppy iris, virtually all of the techniques that you've heard about will work, including intracameral epinephrine and Helon 5 and even preoperative atropine. The moderate cases, I think Helon 5 and intracameral epinephrine work well, but in a severe case, I think that the most reliable way to deal with this is with either a pupil expansion ring or with iris hooks. Now, the pupil expansion rings work well. However, they're difficult to place if you have a shallow chamber. They're also difficult to place if the pupil begins, as it did in this case, with a very small diameter, because it's harder to thread these rings into place if the diameter is small without causing trauma to the iris. So, and the other advantage, I think, of iris hooks is if you have a brunescent lens, you can continue to use high vacuum techniques such as chopping, because again, with Helon 5, you really cannot use high vacuum or high flow rates. So here, as you see, we've disengaged the hooks. You don't want to pull the stop completely off, and then you rotate by nudging that little silicone knob. You rotate it so that the hook is in the same plane as the paracentesis incision, so it doesn't grab the incision lip or iris on the way out. And here you can see I'm just putting them back into the holder. Now, what I've been doing each time I remove these is I shake them in a little cup of sterile water to rinse off the viscoelastic, and then I've been placing them, and I'll do this on the last one under the microscope, on a little moistened instrument wipe, and then by dabbing it I can sort of clean off the last bits of viscoelastic. I then place it back in this little autoclavable container. The lid pops back on that, and then we sterilize them and wrap them for the next case. So you can see here that this really hasn't damaged the iris sphincter, and now that we pull out the hooks and we remove the viscoelastic, you'll see the classic behavior of a floppy iris. And I think this is fairly convincing evidence that were we not to have used the hooks, this would more approximate the kind of iris behavior that we would have been struggling with during phaco and cortical cleanup. So here the pupil comes right down, and I think shows again that with these elastic pupils you can stretch them maximally without causing permanent sphincter tears and permanent enlargement.